Is the name behind of me okay, or
No, it's
Yeah.
okay.
Yeah, we all
Yeah,
look
we can see-
reversed.
Yeah.
okay.
Yeah.
Okay. So, can I start, Hillary?
Sure, do. Yes,
Okay.
but I don't start, you start.
Yeah, I do. No,
Okay.
I'm asking because you were.
Oh, yeah.
Okay. So, okay, it's 12. It's actually 12:02. Let's get started. I want to welcome everyone and thank everyone for tuning in today for the MSK case presentation series. My name is Aline Serfati, and I'm the new president of the Radiology Society of Rio de Janeiro. On behalf of my collaborators, Silvana Mendonça and Pedro Dias from Rio de Janeiro, Brazil, and Hillary Humans, Berangamini, and Philip Timmer from the US, we are very happy to kick off the year with the first session focused on sports imaging. I'm also happy to announce that OCAD has a new website, which is ocadmsk.com. And just a little bit of housekeeping before we begin. If you have questions, please put it into the chat box. And at the end, the speakers will respond to them. This video will be recorded and will be available on demand on the OCAD website and on the YouTube channel of the Radiology Society of Rio de Janeiro. Reminder, attendees have not been given the permission to screen record any of these presentations as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding, and without further ado, I will introduce our first speaker today. We have the pleasure of having Dr. Mohammed Samin join us today. He's an assistant professor of musculoskeletal radiology at NYU School of Medicine. He completed residency at Yale, followed by a fellowship in MSK Image and Intervention at Brigham and Women's Hospital. He's very involved in MSK research and education and has authored many peer-reviewed scientific articles, written book chapters, and presented at radiologic and orthopedic national conferences. He has received many awards related to his work, including an RSNA Certificate of Merit for his presentation on MR imaging of superior capsular reconstruction for irreparable cuff tears. We are delighted to have him here today. And with that, I'll turn it over to him.
Can you hear me?
Yeah, we can.
Okay, great. Thank you so much for your kind introduction. Thank you, Dr. Humans and Dr. Serfati for the invitation. It's definitely I'm so pleased to be here and to be part of this and present among this distinguished my distinguished colleagues. So the theme I think is the for this case for MSK case conference would be they focus on sports injuries, and I am going to start. I have no disclosures. I'm going to show you an indexed case, and after going through the case and basically going through the diagnosis, I'm going to show you 3 or 4 more cases which can be similar in terms of presentation. So the indexed case is a 20-year-old male with football injury, fell on the side following being hard tackled. He presented with hip pain and ecchymosis about the right iliac crest. I'm just going to show you images. They're axial and coronal, fluid sensitive on the left, and axial, and I think that's the axial PD and the coronal T1. And I'm just gonna let you look at it for a second. And then move on to the next slide, which are basically the sagittal images at the level of the injury. Again, on the left, I have fluid sensitive, and on the right is also PD non-fat side. So as you have noticed, they're on axial and coronal fluid sensitive, shows extensive edema and hemorrhage, which is about the anterior right iliac crest, and that extends to the abdominal wall muscles, oblique, external and internal oblique muscles. And then if you look more carefully, you will see a linear low signal associated with those muscle fibers and at the region of hemorrhage and actually edema, which with a focal cortical defect of the right iliac crest. On the sagittal images, you see it also nicely that there is a fracture fragment evolves from the iliac crest. There's a lot of hemorrhage and edema in that region. And again, you can see the muscle fibers attaching to that ossific fragment, which has pulled off from iliac crest. So going just through the anatomy a little bit. Abdominal wall muscles anatomy is going to be critical in terms of making these diagnoses. So starting with, and I'm using Netter images, the good old Netter, and you see that the external oblique muscles, which do arise from the 8 fleshy digitations, each from external surface of lower 8 ribs. The digitations are arranged in an oblique line which runs inferior and anterior, and that's the way you can you can basically look at the orientation of the muscle fibers and say this is the external oblique muscle. And what is relevant to our case is that these fibers are inserted into the anterior half of the outer lip of the iliac crest. Just compare that to the internal oblique, which fibers run sort of perpendicular to the external oblique. If you compare these two images, they begin in the thoracolumbar fascia of the lower back. They also have origination of the anterior 2/3 of the lower back, the iliac crest, and the lateral half of the inguinal canal. The muscle fibers run sort of horizontal and a little bit actually supermedially, and ultimately they insert into the ribs, lower ribs 10 and 12, and the linea alba. So this is the coronal T1 of the same patient. As you can see, this was if I remember correctly, this was probably the most anterior slide, so I couldn't go more anteriorly. You see the rectus abdominal muscle here, and based on the muscle fibers, now you can tell this is the internal oblique, and those fibers which are coming from the actually posterior kind of to the anteromedial direction are the internal oblique. And I start to scroll back again, you can see the internal oblique muscles and external oblique muscles coming. You can definitely appreciate the different direction of those. And as we go back around that area, we can see those muscle fibers of the internal oblique are attached to the muscle fiber. So this was a case of avulsion of the iliac crest from contraction or injury to the internal oblique muscles. It has a name that I did not know before my fellowship when we were reading for one of the professional football teams that they had an injury. And for those that deal with these professional teams, they know what I'm talking about. If anything happens, no matter what time of the day or night, they're going to call you and they say, we think this is what it is. When's the next time you can do an MR? And obviously once the MR is done, they want to report. So they told us we think that's a hip pointer, and honestly I didn't know what it is. So for those that were never heard of that, this is also known as the iliac crest or graded trochanter contusions. It was first described in 1966, and at the time it was proposed that the hip pointer be used only to describe the contusion of the iliac crest after a direct blow to the area. But also other proposed mechanisms for this injury is a sudden compression or contraction of the abdominal muscles against the iliac crest. They are more common in contact sports such as football, like American football or international football, soccer, hockey, rugby, and it happens particularly in the elite levels. In American football, it is typically a result of a sudden direct blow on an unpadded or even sometimes padded area of the iliac crest. I'm not sure why it's not. It was supposed to be a loop, but it's not looping. So as you can see, this runner back, I mean, he got tackled, and he got a direct hit from one side from a player who tackled him, and then he fell completely on his left side. And this is a very common mechanism of injury in American football. On other sports, it is also possible to sustain this injury from fall onto the hip during sport, reported both in soccer and skiing. And hockey players often get injured when they sustain or there's a hard check of those players into the boards. In terms of epidemiology, there was a large study in the NFL, National Football League football players between 1997 and 2006. There was a total of 738 hip injuries, with 33% reported as contusion and 82 were reported as hip pointers, which accounted for 35% of total hip contusions. The mean days that these players can miss training is about 5 to 6 days, which can be significant for very elite players. And usually patients present with pain over the iliac crest associated with some difficulty ambulating. This pain can be very, very severe, specifically at the beginning, and can result in significant decreased function, and the athlete can miss training and gain participation depending on severity of the injury. In terms of imaging, radiographs usually are not obtained unless they want to rule out fracture, or in younger athletes for apophyseal avulsion in skeletally immature patients. MRI is the imaging of choice, which can show hematoma, strain of the muscle contusion, or avulsion injury, as we saw in our case, and oftentimes fracture. It is important to look for other intra-abdominal injuries because the impact of these are the result of a really high impact injuries. Treatment is usually conservative with pain medicine. Surgery might be indicated if the fracture is big and is displaced and results in muscle dysfunction. The most important is the prevention, and as you have seen, these athletes, they can wear a very big and thick paddings over the iliac bone or the hip bone, and that's pretty much to prevent these injuries. So few companion cases. All of them are from football injury. This is a 15-year-old with football injury. 2 months ago, he did not seek any medical treatment at the beginning, and he continued to play. A few days later, he basically sustained another injury, after which he was not able to weight bear. The coronal, sagittal, and axial, all fluid sensitive. As you can see, there's a substantial edema around the distal iliopsoas tendon. And there's also avulsion of the apophysis of the lesser trochanter. So this is a partial avulsion injury of the lesser trochanter apophysis with some injury to the tendon. Interestingly, in the same MR, you can see there's resolving anterior inferior iliac spine non-displaced avulsion injury at the origin of the rectus femoris, as you can see here nicely here. And that was presumed to represent the initial injury the patient had and did not basically ask for or seek medical attention. Second companion case is a 20-year-old runner back, again, sustained football injury and presented with growing pain. Again, I'm going to let you look at the images for a second. And as you can see, there is edema involving the pubic symphysis and parasymphyseal pubic bone bilaterally. When you see that pattern, obviously you want to think about athletic pubalgia or injury to the rectus abdominis or adductor aponeurosis. Looking for cleft sign, And this patient did not have any evidence of that, and ultimately diagnosed with osteitis pubis, which can be sports related due to different mechanisms such as instability or stress injury, depending on what they do. And ultimately, the last companion case is a 21-year-old with hip and groin pain following a recent football injury. This was a very interesting case, and when we saw, and as you can see, patient has joint effusion. There is some contusion of the femoral head, and we didn't see there were any fracture associated with that, so we ended up calling this contusion. And as you can, if you look at the ligamentum teres origin from the fovea, it is partially torn. So it was a bone contusion, partially tear of the ligamentum teres with joint effusion. And with that, I want to thank you again for your attention and for the invitation.
Thank you, Mohammed. Great cases.
Hello?
I can hear you, Hillary.
Yeah, but I don't see me.
You don't see
And
me.
I think I
regardless,
should stop sharing, right? Yes. Yeah. There you go.
okay. Hello. I'm introducing Dr. Ivan Godoy. He's practicing musculoskeletal radiologist at the Hospital de Coração and Imagem. He completed his residency at Santa Casa de Misericordia de Sao Paulo, and that was followed by his fellowship in musculoskeletal imaging and intervention at the Hospital de Coração, and a research fellowship at Mass General Hospital. He's very involved in musculoskeletal research and education, and has authored several peer-review scientific articles, written book chapters, and presented at radiologic national and international conferences. He's currently conducting doctoral research at Federal University of Sao Paulo. He's a member of several radiologic societies in Brazil and a member of the International Skeletal Society.
All right. Thank you for the kindly introduction. Let me just share my screen here. Are you guys seeing my screen now?
Yes, we are.
All right. So thank you very much, Dr. Strafati, for the invitation as well. So my case is a 29-year-old man with intense pain on left anterior chest wall during bench press exercise. Also, he heard an audible pop when lowering the weight, just like this illustration here on the right, and had immediate functional deficit. Here is just a video from a paper from a friend of mine, an orthopedic surgeon, showing a similar lesion as our case. Please take a look here at the anterior left chest wall, where you can see a tear of the pec major here with a medial retraction here of the pec major, and look at the lowering of the bar here with the weight at the side of the tear of the pec major. So our case is similar than that. You can see in this video from superior to inferior, this axial T2 fat set images, where you can see a complete tear of the pec major tendon here at close to the humeral insertion with this medial retraction of the fibers. You can see some fluid collection and a hematoma at the anterior chest wall here. And also on the coronal T2 fat sets, you can see this edema on the clavicular and also the sternal portions of the pec major. And here's the tendon retracted medially. So the key images of this case, you can see here on the axial, is the complete tear of the pec major tendon with this medial retraction here, and also this fluid collection with a hematoma on the anterior chest wall. And on the coronal images, you can see this medial retraction as well on the sagittal T2 fat set images. So usually those cases of pec major tears in visual inspection, you can see this huge hematoma on the anterior chest wall. They usually extend here for the proximal arm. And in chronic tears and unrepaired tears, you can see this depression here at the anterior chest wall, where the tendon or even the myotendinous junction of the pec major was torn. So pectoralis major tears are injuries that are more common due to increase the popularity of weightlifting sports during the last 20 years, such as CrossFit here on the right at this image, and bench press as I showed before, Olympic weightlifting, such as this case here on the right, and also in other sports activities such as rowing, ski, and fighting sports that are very popular here in Brazil, such as judo and jiu-jitsu. Functional deficit and cosmetic deformity is very common in those cases, and surgical repair is associated with improved outcomes, as I'm going to show later on. So the pec major anatomy has a complex anatomy, usually with two components. Here is the superior component of the clavicular head, and also we can have 6 or even 7 sternal heads in a fan-shaped structure on the anterior chest wall. And until 2010, there was 365 reported cases in the literature, but I'm thinking there's much more than that. And most of them were related to weightlifting exercises such as bench pressing. Ultrasound and MRI are the best tools for evaluating those cases. And the most challenges we can face as radiologists are the inconsistencies in injury classifications, such as this illustration here from this paper from Radiographics. And you can see we can have like a tear at the muscle belly of the pec major, usually due to direct trauma at the anterior chest wall. Also, we can have a myotendinous tear, an intertendinous tear of the pec major, also an avulsion of the pec major tendon, or even a bony avulsion at the side here at the humeral shaft. Also, we have to pay attention that the pec major tendon is a U-shaped structure, and you can have like partial tears only in one of the layers of the pec major, involving or just the sternal or the clavicular portions of the pec major tendon, and though sometimes this can be hard to identify on ultrasound or even MRI images. So where to look for pec major tears in MRI scans? You should look for at the muscle belly, as I said before, usually on direct trauma to the anterior chest wall, and also the myotendinous junction. Those tears are more common, as well as the tendon tear, as I showed on my case before. So here's a companion case showing a myotendinous junction tear of the pec major, here with the huge gap and a discontinuity of the myotendinous junction of the pec major with the hematoma and some fluid collection here on the anterior chest wall. On the coronal tissue images, you can see there's also edema on the sternal and the clavicular portions of the pec major muscle. Here also this fluid collection is a hematoma of this myotendinous junction tear of the pec major. Another 2 companion cases here after a ski injury, you can see myotendinous tear of the pec major, and still there's a tiny visible tendon here near the humeral shaft. This was with a conservative treatment, and the patient was not in an elite level sport practice, so he was fine with that treatment. And here we had another case of a bench press injury with a myotendinous junction tear of the pec major, involving mostly the sternal component. And here you can also see a tiny reminiscent of the pec major tendon. And this was a tear mostly on the sternal head, as confirmed on surgery. Most of the treatment of the pec major tears are surgical, such as this illustration here on the left. You can see this primary suture of the pec major tendon and myotendinous junction. The surgeon goes here on the anterior chest wall and fixates here the tendon near the humeral shaft with one of two anchors to try to reinforce here this tendon. But when the tear is huge, or even with a massive hole here on the anterior chest wall, the surgeons may opt to use an Achilles graft or even hamstring graft to try to cover this tear, as shown here in this illustration on the right. So as radiologists, we should focus also on the post-operative changes due to the tear and reconstruction of the pec major tear, such as this case here, where we can see this Achilles graft here on the anterior chest wall, trying to cover the tendon tear of the pec major. You can see that it's a normal aspect of a postoperative imaging, and the Achilles graft is going anteriorly to the humeral shaft and also anteriorly to the biceps tendon here at the level at the humeral diaphysis. Also, we should focus on the muscle belly of the pec major and try to look for fatty atrophy that can be important for the patient to regain strength during the sports activity that he will practice later on. Another key image that we have to focus is the imaging protocol. The pec major protocol is different from a routine shoulder MRI. So we can use this body coil here on the anterior chest wall to try to cover the whole muscle belly of the pec major and also the tendon of the pec major at the humeral insertion. So it's very different from a traditional shoulder scan where it doesn't cover here the tendon or the muscle of the pec major. We can also use ultrasound to evaluate the tendon or even the muscle belly of the pec majors, but we have to remember that sometimes those athletes are at elite levels. They could bench press like 300 pounds or even 150 kilos. So it's very hard for us to scan at once with the ultrasound the whole muscle and the tendon of those patients. And that's why we prefer MRI for those cases. And here some hot tips from a paper that I wrote with my colleagues at Mass General. We described some secondary finds of high-grade tears of the pec major tendon, such as this case here. We described the anterior dislocation of the biceps tendon and this triangular-shaped hematoma close to the humeral shaft as secondary tears of high-grade tears of the pec major tendon, such as this case that was confirmed on surgery. And here we can see these retracted fibers from the clavicular portion and here from the sternal portion of the pec major, and this hematoma and anterior dislocation of the biceps tendon. So my take-home points of those cases: we should always focus on the tear location, if it's the muscle belly, the myotendinous junction, or even the tendon of the pec majors. We should try to classify it as much as possible as a partial tear, a complete tear, and try to differentiate which layer of the pec major was involved, such as this case here, where the clavicular portion of the pec major was involved, but also we had a complete tear of the pec major tendon with this anterior dislocation of the biceps tendon and this triangular-shaped hematoma. There are secondary findings of high-grade tears, and also as radiologists, it's our job to evaluate the postoperative changes, such as the quality of the graft and the quality of the muscle belly of the pec major. Thank you very much for your time. Let me just stop sharing my screen. Thank you very much.
Thank you, Ivan. Great cases. Now I'm introducing Dr. Jair Letério. He's a practicing musculoskeletal radiologist at IME and Afidea in Lisbon, Portugal. He completed a residency at Instituto Nacional do Câncer, followed by an MSK fellowship at Beneficência Portuguesa de São Paulo, and a visiting fellowship at the University of California, San Diego. He's currently conducting doctoral research at Nova Medical School in Portugal. And in Rio 2016 Olympic and Paralympic Summer Games, he served as an MSK radiologist. He's involved in several educational activities in Brazil, and he's a member of several radiology societies in Brazil and in Europe. With that, Jair, please share your screen.
It's okay, can you see it?
Yes.
Okay. So thank you. Good morning, good afternoon. Thank you, the CAD group and organizers of this meeting for the invitation. Special thanks to Dr. Aline that challenged me to talk about. Just a second, I have a problem here. Let's try again. Can you see my screen?
Yes, I do.
Yeah, okay. And so Lini challenged me to talk about how to get injured practicing sports in Brazil. So Brazil has a tradition in sports like soccer, volleyball. We had our times in Formula One, tennis, mixed martial arts. So let's go to the presentation. You are all experiment. You are an experiment audience. Just a second. And so you are all used to see images like this, a complete tear of a mid substance, complete tear of anterior cruciate ligament with edema. Here is a dedicated ACL sequence showing the fibrous disruption. Here in coronal plane, the edema in the ACL fibers in lateral, and also sprain of the lateral ligament. Or cases like this, a recreative soccer player that twisted knee and has a proximal fibers disruption of the anterior cruciate ligament, soft tissues edema, posterior capsule edema. Here is a dedicated sequence to the ACL showing the tear, the fibrous disruption. In this case, we also have a peripheral tear of the posterior horn of medial menisci and a lateral collateral ligament sprain, the axial plane. But the real clinical situation that I would like to introduce, in fact, is the following. Let's see this 44-year-old male. I will deliberately hide the story of the patient. So we see here a edema in the soft tissues in the lateral part of the left knee. And we see edema particularly around the lateral ligament and at the soft tissues in front of the lateral ligament. Well, in coronal plane, we see edema of the proximal portion of the lateral ligament and edema in the soft tissues a bit below it. So how about the ACL and MCL? If we look those structures, we are going to see the ACL, also the PCL and MCL, they are intact. Well, with this, we can see that we have a different pattern comparing to the first two cases. So let's see another one. This case, we see soft tissue edema here around the lateral aspect of the knee. We see that the ACL, PCL, MCL, they are also intact. We see edema in the soft tissues in front of the lateral ligament. Here in coronal plane, we see this lesion. We see even a kind of some kind of detachment or something like this, and we see the soft tissue edema in front of the lateral ligament. ACL, PCL, and MCL are also intact in this case. And another one, the same pattern, edema around the soft tissues in the lateral aspect of the knee, ACL, PCL, and MCL intact, this edema in front of the and lateral collateral ligament. Here we can see the cutaneous marker. ACL and MCL, as we have previously said, they are also intact here. So, what do all those patients have in common? They all practice this gentle, tender activity that's Brazilian Jiu-Jitsu, BJJ. And so we are looking for, in those particular cases, isolated lateral collateral ligament complex injury related, in this case, to Brazilian Jiu-Jitsu practice. Kleiss published this paper in 2013. He proposed a LC lateral collateral ligament complex term, and we have this complex composed of lateral collateral ligament and anterolateral ligament. In this illustration here, we can see the close origin of both structures. We do not intend to debate or be dogmatic about the controversies concerning the details of this particular anatomy. We think it's beyond the scope. Here in this illustration, we see some people think it's proximal and posterior, some that it's ahead of and inferiorly considering the origin of the lateral collateral ligament. In the lateral femoral epicondyle, this cadaver specimen, beautifully shown here, the kind of conjoined origin of this origin and the in its course to the tibia and fibula here. So we saw some isolated lateral collateral ligament injuries that are infrequent lesions. We had the chance to see some of those cases in Brazil, where Brazilian Jiu-Jitsu is a very popular activity. We found sparse literature and references about this specific subject. 2015, Davis published this paper in Skeletal Radiology. He assembled two cases, one of them Brazilian Jiu-Jitsu of isolated injury to the lateral collateral ligament complex. With this, he brings some lights to the subject, review and discuss the anatomy, and make some interesting guess concerning the mechanism of injury. He states that Brazilian Jiu-Jitsu puts unique stress to the knee, so it's able to produce atypical injuries. Back in 2015, Davis found no reports of isolated lateral collateral ligament complex injuries, but some reports are relating this lesion to anterior cruciate ligament injuries. If we search in PubMed right now, we will find out that Dave's article has been cited only 4 times, what somehow corroborates our assumption that this lesion may be kind of undercovered in literature. Davis proposes a mechanism of various stress on a flexed knee with a varying degree of tibial rotation. There is illustrated in this picture hip flexed, knee flexed, and this stress on the knee. Here are images of Dave's article, and the pattern of the lesion is very similar with considering our ones. So, and to take home and be aware of such a isolated lateral collateral ligament complex tear lesion. We have seen this in jiu-jitsu, but maybe we can find it in other similar martial arts. I would like to thank the OCAD group and the organizers for the invitation. Invite you to visit this social media, MSK Radiology 1, where we share some of our interesting cases. And I also share my email in case any of you would like to comment, make comments, considerations, or critics about these subjects. Thank you.
Okay, can you please unshare the screen? It's my pleasure to introduce Tatiana Gorbachova. She's the section chief of musculoskeletal imaging at Einstein Medical Center in Philadelphia, and she is clinical associate professor of radiology at Jefferson Medical College. I hope I say this right. She graduated from Donetsk State University, Medical University in Ukraine. She completed a clinical research fellowship at University of Southern California in Los Angeles, then diagnostic radiology residency at Drexel University in Philadelphia, followed by a musculoskeletal imaging fellowship at University of California, San Diego. She is currently assistant chair of musculoskeletal imaging of radiographics. By the way, she loves sports imaging and MRI, as well as rheumatologic imaging, and she loves resident and medical student education. Okay, Tatiana, take it away.
Thank you very much, Hilary, for a great introduction, and also thank you and Aline for letting me be a part of this session. This is fantastic. I've been taking notes, I'm learning, and in particular, the last case that Dr. Eleuterio presented emphasizes that we develop so much respect to the posterior lateral corner. So I'm gonna finish this session trying to bring the respect to the medial corner. And I'm gonna share my screen. I hope you all could see it now. My case is about a 39-year-old man with bilateral knee pain after a motorcycle injury. So motorcycle is a dangerous sport. I don't have his x-rays, but I do have those from 2 other patients who showed identical abnormalities on subsequent MRI. I'm going to use those AP views of the knees as an example of marked soft tissue swelling along the medial joint line. Reportedly on exam, our patient had tenderness medially, valgus instability, but he could not be properly tested because of the pain. He came for MRI examination of his right knee approximately 4 weeks after injury, and here are the sequential proton density weighted fat suppressed coronal sequences, anterior to posterior, depicting 2 salient components of his injury: a full thickness tear of the ACL and injury to the medial collateral ligament complex. We're going to focus on this area. And as you evaluate the structures, I would encourage you to do that 3-dimensionally, anterior to posterior, proximal to distal, and in layers, which is deep to superficial. Here's the layered approach that divides medial supporting structures into a superficial 1, intermediate 2, and deep layer 3, or a capsule proper. So MCL complex encompasses layer 2 and 3. The intermediate and deep layers, those 2 and 3, unite posteriorly to form posterior oblique ligament, a POL, which cradles the medial femoral condyle. we're going to stay in this midsection for the purpose of this case. We will not go into the posterior medial corner. And MCL is going to be the star of our show. We will get to it in a minute, but let's acknowledge these structures. A crural fascia, invest the sartorius muscle, level 1, and then deep to it, between level 1 and 2, we have gracilis and semitendinosus tendons. The pes anserinus, right? It's got its name because it looks like a goose foot. It's silly mnemonic that helps to remember the order of the tendons is, say, grace before T, T for semitendinosus as opposed to another popular tendon, semimembranosus. It has its own bursa, which is located more anteriorly and distally than other medial-sided knee bursa that we used to see. And the pes anserinus joins tibial periosteum distally and anteriorly as it crosses the very distal aspect of the tibial collateral ligament. Tibial collateral ligament, or superficial MCL, is that distinct vertically oriented structure that greets us on a sagittal scroll. It looks like a seat belt with its proximal attachment on the medial condyle and distal attachment on the tibial metadiaphysis, quite distally, 6 to 7 centimeters below the joint line. So that's the superficial MCL, or tibial collateral ligament. It's about 10 to 11 centimeters long. It has no meniscal attachment. Beneath the tibial collateral ligament is the joint capsule proper, or layer 3. And its localized thickening deep to the tibial collateral ligament is referred to as a deep portion of the MCL. It holds the meniscus to the tibia and the femur, so we identified its menisca femoral and menisca tibial components. Here we go, deep and superficial components of the MCL, closely opposed under normal circumstances. MCL bursa may separate the two layers. So when we talk about grading of MCL injuries, they're best graded clinically, and clinical classification takes into account MCL as a whole structure, deep and superficial. So grade 1, tenderness, but no loss of function. Grade 2, partial tear, there is some gapping with firm end point. And grade 3, complete tear, gapping, no defined end point. So it's very easy and tempting to grade MCL injury based on its superficial component. Grade 1, 2, 3, based on presence and extent of fiber discontinuity, but we're not grading the whole structure, only part of it. And in doing so, oftentimes we will not be accurate and consistent with our clinical exam. So deep MCL should receive no less attention. We can see its avulsions radiographically, which are more distal than so-called Pellegrini-Staieri avulsion, which is at the epicondyle. So with deep MCL avulsions, we can see them on MRI, and it's not uncommon to see extensive bone marrow edema-like signal that accompanies these avulsions. It's not very common for avulsive injury to give you bone marrow edema, but this happens in those situations anatomically, then direct attachment, like in this case, deep MCL, happens at the right angle to the bone, as opposed to tibial collateral ligament that has an oblique indirect attachment. So its avulsions are oftentimes have no or minimal associated marrow changes. So what about our case? There are several things that are going on here with the MCL complex. We have diffusely edematous deep MCL with a full thickness tear at its menisca femoral portion. We have a very lax appearing tibial collateral ligament because of the distal tear. And then additionally, there is an interposition of the pes anserinus deep to the tibial collateral ligament that is referred to as a Stenner-like lesion. So the original Stenner lesion of the thumb is the situation when torn UCL is displaced superficially to the adductor pollicis aponeurosis, and such aponeurotic interposition prevents anatomic ligament to bone healing of the thumb UCL and necessitates surgical intervention. So Stener-like lesions of the knee have been described in ortho literature and only very recently in radiology literature. So it's the distal tibial collateral ligament that gets displaced, and pes anserinus is playing the role of the aponeurosis interposed under the stump. So I picked this case that I showed you because the patient had trauma of both knees. And we also have images of the other side that had a different pathology. But I flipped it and I put it next to the knee in question so we can see the normal and abnormal relationship between the tibial collateral ligament and pes anserinus. So let's watch this superficial MCL or tibial collateral ligament, and let's watch our three musketeers, the pes anserinus tendons, how they approach the distal insertion, and look at the normal relationship on this side. Here goes the stump over here, and look how it starts to be located superficially to the edge of the pes anserinus, and more distal sections, it's completely superficial to the pes anserinus. And here it is on the coronal sections. Now we watch those pes anserinus tendons, and look, the stump is located superficially. That's an abnormal relationship. So here are the key images of the Stener-like lesion of the knee, the interposition of the pes anserinus between the distal distal medial collateral ligament and its tibial attachment. Such interposition prevents anatomic healing of the tibial collateral ligament, creates potential for residual valgus instability, and oftentimes prompts surgical intervention. This is the paper from Doctors Erin and Michael Alea and Zehava Rosenberg that concludes that Stener-like lesions represent high percentage of tibial-sided MCL avulsions. Oftentimes, they're associated with multiligamentous injury. And authors encourage us to carefully review the distal ligament at all MRI planes because expected distal attachment may be excluded from the field of view on one or more imaging planes on routine protocols. And in my opinion, this is frequently the case. But the good news is, once you have seen few examples of this lesion, one plane may be just enough. Are there any other interposition lesions in the knee that we should be on a lookout for? Yes, I'm going to show you my two other favorite ones that are not that rare. It's the pediatric periosteum. Normally, it's attached rather loosely. So in Salter-Harris injuries, it can be stripped from the cortex on the distraction side, and what can strip can get entrapped. So during reduction of displaced transphyseal fractures, that stripped periosteum can get entrapped and lead to inadequate reduction radiographically. And that inadequate reduction radiographically, I want to emphasize that not all of those lesions need surgery, but if this is the cause of suboptimal reduction, that necessitates the surgery. So look for that dark periosteum, either stripped or entrapped. Look at this dark tissue interposed in the physis when you have your pediatric injuries. And another interposition scenario in the knee that happens with avulsion fractures of the intercondylar eminence at the ACL attachment. So the treatment of those avulsions, as we know, depends on the degree of fragment displacement, right? It's elevation, rotation, and so on. So we look at the fragment. We also look if the footprint of the anterior root of the lateral meniscus and ACL are both encompassed by such a fragment. And by the way, some authors believe that it is the anterior horn of the lateral meniscus and its root pulling on the tibial eminence fragment that causes the fragment displacement and failed attempts at close reduction. it just pulled by those anatomic structures. But there could be true soft tissue entrapment or interposition, namely of this ligament, transverse meniscal ligament. We all see it quite frequently. It runs across and it runs right anteriorly to the tibial eminence avulsion. And here's the case I wanted to share. Look how, watch for this ligament and watch how it gets under the fragment, and it's quite elevated and it prevents its reduction. So in the conclusion, if you hungry for more interposition lesions, want to see more entrapments on other joints, I suggest you visit this beautiful RSNA exhibit from 2015, a marvelous award-winning one, and you'll see other interposition lesions and other joints. And thank you so much for your attention.
Thank you, Tatiana. I don't see any questions here on the chat box. If you have questions, please put it into the chat box. Beautiful case of standard-like lesion of the MCL from Dr. Lambert. Thank you.
Thank you.
Any more questions?
I have a question for Ivan, if you don't mind.
Sure.
Your strategy, then those pectoralis injuries are not suspected clinically, and you start to suspect it when you do routine shoulder MRI. It just doesn't go far enough distally. What's your quick and easy, if you cannot run another whole protocol, or would you rather run another full pectoralis injury protocol? Is there a cheap way to add sequences and quick way to your routine shoulder and make the diagnosis? Or would you go for the full pack 40-minute scan?
Yeah, that's a great question. We are facing this problem more frequently because we scan some athletes that are currently doing this bench press exercises at an elite level, and sometimes the orthopedic surgeon just order like a shoulder MRI and suspecting for rotator cuff injury or even a pec major injury. So we face this challenge: which one should we choose? And sometimes we do an extended protocol with the shoulder, trying to do at least the axial images, going further down to try to track the pec major tendon. And if there's a suspected tear, we then try to add the whole pec major scan, so that the patient is not asked again to return to the radiologist service and then get another scan. So we try to get as much as image as possible for those cases and try not to miss those pec injuries. But sometimes it's hard to fit in the whole scan of the pec major, which is longer than a traditional MRI of the shoulder. So at least the axial images, T1 and T2 fat set, we try to include in those protocols when a pec major tear is suspected.
Thank you.
Right.
I have a question to Ivan.
All right.
Ivan, is it a very challenging situation to scan those patients with ultrasound?
Yeah, sometimes it is. As I said in the presentation, those patients are very strong, like with a huge anterior chest wall, and sometimes you have to scan as like this panoramic field of view from some ultrasound machines. But it's very hard. Sometimes it's very thick, the pec major muscle belly, and the tendon is very deep. So it's hard to find those tears sometimes. And that's why we always prefer MRI studies. But at some levels, like during acute tears, ultrasound can be very useful for trying to identify some fluid collection, hematomas, and also some pec major tendon avulsions. But mainly those cases of this pec major athletes, as I said, it's very hard to scan with ultrasound. Sometimes the MRI is the best choice.
Okay. Thank you.
Can I have a question for Dr. Eleuterio here? My question about your cases. Any of those isolated injuries were surgical in your experience?
No.
Another questions coming from the audience. So thank you.
Yeah. No, in fact, it's described in the articles that the conservative treatment is very useful for these cases, and the patients are usually recovering well. And also there is a article from a group from Minas Gerais in Brazil and France, and there is a little bit more, this is an orthopedic article, and he also states that conservative treatment seems to be adequate for this particular situation.
A question from Roller Pedersen. Pectoralis major, is it important to identify exactly which part of the tendon that is ruptured at the humerus?
Yeah, sometimes the protocol may vary between different scans, and sometimes it's hard to get a sharp image of the pec major tendon. And sometimes it's very hard to differentiate which layer are we seeing, like the clavicular portion or even the sternal portion of the pec major tendon in that U-shaped, as I said before. But my take-home points, I think it's the key part is try to see if there's a high-grade tear with that biceps tendon anterior dislocation and that triangular-shaped hematoma near the humeral shaft. There's probably a high-grade tear. And then we're probably going to try to call it like a partial tear or a high-grade tear or a complete tear with bony avulsion. It's not that important for the surgeon if we try to differentiate which layer of the pec major tendon is involved. It's more important for us to try to measure the retraction and to inform him it's a high-grade tear or a complete tear. That doesn't matter for them that much which layer it's involved. Much of the cases are surgical anyway, so try to reconstruct this anterior chest wall is a very challenging surgical procedure for them, so most of them are going to that surgical approach.
Thank you, Ivan. Another question from the audience. Jiu-jitsu injury, do they have second fractures anytime without ACL ruptures? I think it's for you, Jay.
Yeah, that's a good question. We haven't seen this, no second fractures, but when we were reviewing the anterolateral ligament anatomy, I suggest this Klei's, Dr. Klei's paper, and he states that the insertion of these anterolateral ligament may be related to second, but not in our particular case. But I do recommend, it's a very interesting, historically in the anatomy and also radiology, it's a very interesting anatomic subject, the anterolateral ligament.
Thank you, Jay. Another question for Ivan.
Right.
What's the FOV for Dr. Ivan uses for Pectoralis major?
So our routine pec major protocol uses field of view. The axial is like 26 centimeters long, like the width of the pec major crossing as an axial is like a box with 26 centimeters. But sometimes those patients, those athletes are very large, and we have to get a larger field of view and try not to get a distorted image. And sometimes those athletes have to, like, go on obliquely on the MRI scanner, because they don't fit as well as they should, because they are very large. So the field of view from the axial are very large, like 26 centimeters, and sometimes the coronal field of view are like 30 centimeters long. So it's a very large scan to try to cover all the muscle of the pec major and all the tendon at the humeral insertion as well.
Thank you, Ivan. Another question for Dr. Tatiana. Medial interposition. How often do you see interposition of the MCL structures in the joint line? Never?
That's a great question. I think we all have our collection of gory images, you know, of things displaced in the places. I personally never seen the MCL in the joint line. My colleagues do showed me those cases. I should say two, plural. And in Dr. Leia's paper dedicated to MCL, there were two interposition lesions that I believe there were two that actual MCL was in the joint line. So if you want to go to that AGR paper to review those, but that was another mentioned interposition. I think those are rare, but I believe we all seen those examples with the significant high energy trauma. I do believe that happens. I personally never encountered a case of that, but go to AGR Stenner lesion paper and they do show an example of such injury.
Thank you, Tatiana. I don't see any more questions, so thank you all for tuning in. We are all looking forward for the next session, which will be held on February 26th, with focus on sports imaging again. Thank you all for tuning in.
Thank you.
Bye-bye.
Bye-bye.
Thank you.